Okay, next up we'll have Dr. Jocelyn Leu.
Great, thanks. So thank you for the kind introduction earlier, as well as the opportunity to present at this session. And my apologies also for not attending the session in person. So as the title describes, I will be presenting on a rare disease development program at J&J, which involves pregnant women with maternal-fetal incompatibilities. Here are my disclosures. And then to start off my presentation, we wanted to talk about a current development program, but as we were reflecting upon our involvement in pregnancy research, we discovered that it had been more than 50 years since our company has last been involved in research for maternal fetal disease. In the 1960s, investigators at Columbia University collaborated with Ortho Clinical, which was a J&J company, on the development of RhoGAM, initially for the prevention of Rh immunization in Rh negative women during pregnancy. Now, half a century later, 50 years later, we are developing a compound with a specific mechanism of action which lends well to the treatment of specific maternal fetal diseases. So first, I'd like to start with a background on two of the maternal fetal diseases. The first disease I'd like to introduce is hemolytic disease of the fetus and newborn, which I'll refer to as HDFN. This is a rare, life-threatening condition of progressive fetal anemia due to incompatibilities in the mother and fetal red blood cell antigens. This happens when the mother is Rh negative, the father is Rh positive, and the fetus is Rh positive. If the fetal blood enters the mother's blood circulation, the mother's immune system forms alloantibodies. As shown in the diagram, once the mother is sensitized and the next pregnancy occurs, with the Rh positive fetus, maternal IgG alloantibodies then cross the placenta and cause destruction of the fetal red blood cells, which can cause severe morbidity as well as mortality of the fetus and the newborn. And the severity tends to increase in subsequent pregnancies due to repeated alloimmunization. The current management of HDFN involves ultrasound monitoring for fetal anemia and treatment with intrauterine transfusions, referred to as IUTs. IUTs are invasive and could still be associated with increased maternal alloantibodies, complications, and could result in premature or preterm birth or fetal demise. As such, there remains a significant unmet medical need for less invasive interventions in pregnant women with HDFN. The next disease to introduce is fetal and neonatal alloimmune thrombocytopenia, which I'll refer to as FNAIT. FNAIT occurs when there's an incompatibility between the types of human platelet antigens, so HPA, of a pregnant woman and the fetus. When the fetus is HPA positive and the mother is HPA negative but has been sensitized from a prior pregnancy, kind of similar to the HDFN case, the maternal IgG alloantibodies against the fetal HPA cross the placenta, as this illustration shows on the right-hand side, and then causes destruction of platelets, resulting in various degrees of thrombocytopenia in the fetus and the neonate. There are no approved preventative treatments. However, IVIG with or without corticosteroids is currently used off-label for pregnancies known to be at risk for FNAIT. Both treatments, alone or in combination, have unclear benefit risk, and also there's an unmet need for targeted therapies for FNAIT. And lastly, I'll move on to introduce the mechanism of action for the compound we are developing for these maternal fetal diseases, which is Nipocalimab. The FcRn receptor was initially discovered in the placenta, where the receptor is known for the transfer of maternal immunity to the fetus, particularly increasing in the third trimester. FcRn receptors are also found across the body and is responsible for the salvage of IgG from lysosomal degradation and thus recirculation of IgG. Nipocalimab is a fully human, high-affinity, selective, effectorless blocker of the neonatal Fc receptor and thus can inhibit placental IgG transfer, as well as lowering circulating maternal IgG levels, including autoantibodies or alloantibodies. So in this case, an open-label phase 2 study was conducted in HDFN, which supported further investigation for pivotal phase 3 trials in HDFN and FNAIT, which are currently ongoing. So in the next slide, I originally was thinking about sharing the data from the phase 2 study. However, when I was given the 10-minute presentation slot, and the focus on ICH E21, I decided to paste screenshots here of and links also to the New England Journal of Medicine, and as well as the NEJM evidence publication for your later perusal. But then now would focus to the phase 3 study designs, which I think would be of a bit more interest in this case. So first, Azalea is a study name for our phase 3 trial of Nipocalimab in severe HDFN. In this phase 3 trial, we plan to recruit and enroll 120 participants at risk of severe HDFN, and the screening period will occur from gestational age weeks 8 through 16, of which participants can start treatment starting from GA week 13 to 16, of which participants will be randomized 2-to-1 to either Nipocalimab or placebo as weekly IV infusions. Weekly visits, including fetal monitoring of middle cerebral artery peak systolic velocity, notated here as MCA-PSV, and dosing will occur up to GA week 35 or up to when the birth occurs. The primary endpoint is a proportion of pregnancies that do not result in fetal loss, IUT, hydrops fetalis, or neonatal death. As you can appreciate that in non-pregnant studies, typically a participant would have a safety follow-up depending on the PK characteristics of the compound, which could end up being something more like 1 or 2 months for safety follow-up. However, here you will notice that the postnatal safety follow-up will last 24 weeks of maternal follow-up, along with a longer 2-year neonatal infant follow-up as well. The next pivotal phase 3 study is Freesia 3 for FNAIT. And yes, as you've noticed, we have a flower name on the study names of you may have noticed. The study will target an enrollment of 50 pregnant individuals with a similar screening period of GA weeks 8 to 15. For enrollment during GA weeks 13 to 16, and treatment through GA week 37. But the difference with the study also is that we have an active comparator, including IVIG, plus or minus corticosteroids at a 4-to-1 ratio of Nipocalimab to IVIG arm. Dosing will occur every week, along with ultrasound monitoring for fetal bleeding, growth, and development, which will occur every 2 weeks. Lastly, the postnatal follow-up is the same with the maternal follow-up for 24 weeks and neonatal follow-up for 2 years. Next slide, we go through the primary endpoint, which I didn't have space on the other slide, not like the prior one, but the primary endpoint here is the composite of fetal neonatal death or adjudicated severe bleeding in utero up to the first week post-birth, or severe thrombocytopenia, neonatal platelet count at birth. So basically this number here is quite low indeed. And then a few more details to share about the Freesia 3 study design. Here you can get a flavor for the multiple secondary endpoints, which include quite a few assessments which would occur on or after birth with the neonate and the fetus, et cetera, and follow-up period as well as selected exploratory endpoints, including the patient and caregiver reported outcomes, all the ones on the right-hand side, including the PK, pharmacodynamics in this case, as well as immunogenicity. So to wrap up with the key takeaways, research for new therapeutics in pregnancy have been far and few between, even in my experience over here as well, after my years here at J&J. Protocols are more complicated in pregnancy due to assessments in the mother and fetus/infant. And so I won't go into detail here, but from our phase 2 experience, the number of data sets and data analyses for the clinical study report were quite gargantuan, I would say, and much bigger than in the non-pregnant diseases, but also that the research in rare diseases require long recruitment and enrollment periods because number one of the rarity of these diseases, but also longer as well for extended postnatal follow-up and periods for the mother and infant. So last but not least, I'd like to extend acknowledgements to the study participants, investigators, study staff, and study teams for their contributions to these studies, and also to the investigators and study teams who had previously presented these slides for which I combined into this presentation. So that basically is the end of my presentation then, and I guess the next speaker then.